I'm going to speak a little bit over 15 minutes about the future perspectives of the systemic treatment of tenosynovial giant cell tumor. I am a clinical oncologist. I work with sarcomas and cutaneous tumors. I work in the Institute of Cancer in São Paulo and also Hospital Syrian-Libanese. These are my potential disclosures and current positions. And before I actually go to the systemic treatment of the disease, let's talk about the tenosynovial giant cell tumors. Let's call it TGCT. It's rare, non-malignant neoplasms involving the synovium of joints, bursae, and tendon sheaths. And it's actually benign. However, often it can be locally aggressive. And there are rare cases that happens. That usually it's typically present in young and middle-aged adults. 1.8 cases per million of inhabitants. And then the names is it's a little bit difficult, that name. It's basically giant cell tumor of tendon sheath, which is localized TGCT. And then we did nodular tenosynovitis. And then we have the diffuse TGCT, diffuse type GCT, or pigmented velonodular synovitis. So these are the nomenclatures. And then as image goes, this is a lesion, and it's very good radiographically, but poorly defined periarticular masses. We have degenerative joint disease, cystic lesions in the adjacent bone, and the MRI decreased cyanointensity in T1 and T2 weighted sequences. And in pathology, we saw proliferation of mononuclear cells, mixed osteoclasts like giant cells, foamy histiocytes, inflammatory cells, collagenous background, and then the nodular form, like I said, we see low grade, and the diffuse has mitotic countage more, about 5 mitoses per millimeter. The numbers nowadays have, of course, we bring from other countries. We don't know the incidence in Brazil, but according to the North American casuistic, the tumor is localized, and it's more than 90% of TGCT cases, with almost 15,000 new cases per year. It's usually nodular, favorable course, low recurrence rates, less than 10%, and frequently it's manifested in the extremities. These characteristics contrast with the diffuse TGCT, which is about 10% of the others, which only 1,500 new cases in the United States, but typically affecting younger patients, female and male, but more females than males actually, large joints, knees, ankles, hips, and it has an unfavorable course. It's a lot of difficulties there, high recurrence rate. After the first surgery, it's more than 50%. Rare cases of metastatic disease described in the literature, but we understand that it's a disorder that offers local and aggressive local complications than a potential metastatic potential. Of course, it happens, but still it's rare. Here we have some examples completely different than the localized. Localized is totally different than diffuse. The radiological aspect shows the biggest aggressivity, and that's the focus of our discussion about the systemic treatments. Well, TGCT symptoms include pain, using analgesic and opioids is common, swelling, stiffness, joint stability, hemarthrosis, decreased range of motion, ROM, disability and functional impairment, and impairment of the quality of life. So we have this TGCT in their daily routines, and when we see this retrospective, we see that there is a functional impairment for daily activities, pain, and translating that into anxiety, depression, and so on. And people also don't work very well, so there is the laboral capabilities are reduced. More than 1,300 patients with TGCT and controls that we see that there's a big proportion of people going to ERs, to hospitals, using medication, reinforcing the impact of a functional use of hospitals, and also an economic impact affecting a population that are working and so on. So the therapeutic approaches, it's key to say that even though the golden pattern of surgery is, of course, the optimal surgical resection, arthroscopic versus open, and there are studies that say that they reduce pain, improve functionality, minimize the risk of recurrence for open. But of course, these two possibilities are there. And of course, the goal of reducing pain, improving functionality, and so on. For the diffuse form, of course, the recidive, the recurrence is very probable, risk of post-op hematrosis, stiffness. So the substitution of, we have total synovectomy, joint replacement, amputation even. Other strategies that were used in the past include cryotherapy, radiosynovectomy, which is an injection, an articular injection of an oncolytic of 90, and external radiotherapy in doses from 30 to 36 GY. But in this meta-analysis published in 2015, including 630 patients' data, there was a potential role in the perioperative setting with a duration 0.31, but low level of evidence. Typically, we save the radiotherapy for patients in which a surgery is not appropriate, especially for patients in the diffuse form. It's important to see that even when the treatment, the surgical treatment is good, the diffuse have risk of post-operational hematrosis, stiffness and instability, and the recurrence rate is 15 to 50%. So the patient journey in TGCT is very long because there are many interventions that they will have and evaluation by different professionals, which is tiring. So surgical orthopedics, specialists in sports medicine, oncologists, and so on, surgeons, and so on. Sorry. So especially with the systemic agents, it's important to have a clinical oncologist. Until 2019, we didn't have any approved therapies. We had some activities of imatinib, and I will go back to that. But after 2019, we had novelties, carcinogenesis, and molecular insights. This is interesting because this disorder is clonal. It's a neoplastic process marked by T12, putting in aggregate CSF1 co683, and the result is an overexpression of CSF1, macrophage, and CSFR, and this superexpression of CSFR, it takes this overexpression, will take it to reactive inflammatory process. All right, so there's a recruitment of CSF1R expressing cells, but this is part of this tumor. The biggest part of this tumor is this inflammatory component that installs there because of the recruitment of those cells. And this was basis of the approach of there was a phase 1 study with pexidartinib in the journal Medicine in 2015. The drug, the PLX 3397, or pexidartinib, it's a small molecule TK inhibitor, highly selective for the receptor CS1. And all we see here is the ability of inhibition of CSF1R because it selects different agents. And then when you compare to the other drug with imatinib, we see a concentration for the inhibition of CSF1R. So imatinib is a strategy, but pexidartinib is better. We saw a response very good with 20 available or evaluated patients. We saw a response tax of 60% with many responses that were very sustainable, prolonging for more than 20 months. We have here some patients with pexidartinib in phase 1, and it goes beyond what we could measure because there is a volumetric reduction very good. So we did a phase 3 study. There was a phase 3 study. So the pexidartinib was approved by the FDA North American, and it was published at Lancet in 2019. 39 international centers participated, adult patients with TGCT, symptomatics, non-candidates to surgery, and they had their disease, which was measurable. And the study had two parts, a blind, randomized part 1, and the part 2 was open label extension with crossover of patients. So the placebo ones could go to pexidartinib. So the first part, placebo controlled and blinded, and then we had pexidartinib 1,000 for 22 weeks, 1,000 mg per day, reduced to 800 mg per day. And after the third week, we did the crossover in that arm of pexidartinib. So we had 91 patients treated with pexidartinib. They were stratified according, it was United States versus non-United States, and TGCT in upper limbs versus lower limbs. So we're looking for the response level after 25 weeks using criteria based in images, and then the secondary were good information with functional aspects, amplitude of movements, articular stiffness, response, bad responses, and a different way of evaluating, which was the tumor volume score. I'm going to show you the tumor volume score, TVS. This is very important for TGCT because resist, we measure the biggest lesion. So we have that goal lesion, and then measuring this the tumor volume. Of course, it's hard work to do radiologists, but the variability is better. But it's capture all the tumor, so it's good. So then you can reduce that mass, that amorph mass, right? So the population was very representative in the casuistic. We had an age, median age of 44, so 18 to 79 years old for placebo, and pexidartinib 22 to 75. So male, female, knee, or ankle. What we saw here, 5 minutes. Oh, sorry. So we saw a response tax of 40% with pexidartinib, with 0% with placebo, so which was really significant. We have a patient that was treated with pexidartinib with a very morbid lesion demanding amputation, and the response was really good after 3 years with a reduction, a very good reduction of the tumor. About the secondary endpoints, we saw a very good response for functionality, pain, and so on. And then a superior response, which was captured by RECIST when we saw the TVS, tumor volume score. So the response was 55.7% versus 0% of placebo. More recently, there was a pooled analysis, combined analysis, phase 1 in the randomized study, and the part 2 with the patients that did crossover, randomized with placebo. 130 patients with a median age, a median duration of exposure 18.7 months, and we saw a response text that was very objective, 65% by the TVS, with a median response around 3 months. So the responses were very early, very precocious. So we have some peculiarities of pexidartinib, and all the patients that were treated, they of course had some adverse effect, 3 or superior 33%, up to 50%, and toxicity levels that were up to 20% in the cohorts after the standard pattern of pexidartinib dose was established, and it got to 33% of discontinuation because of toxicity. Well, what are the toxicities? So we have hair color changes, nausea, fatigue, AST increase, ALT increase, and arthralgia. So usually ANT is elevated. The pexidartinib has hepatotoxicity. So two clinically distinct types of hepatic adverse reaction, aminotransferase elevations, and mixed or cholestatic hepatotoxicity. They are reversible with other doses, especially during the first 2 days. There is a standard, it's a cholestatic pattern, which you have an increase in alkaline phosphatase with or without aminotransferase elevations, and it's uncommon and idiosyncratic, but it can last longer, maybe prolonged, and irreversible can be. It's rarely serious, but it can be very, very severe and threatening. So in August of 2019, pexidartinib was approved by the FDA for TGCT. There were no candidates for surgery. 400 milligrams twice daily on an empty stomach, at least 1 hour before or 2 hours after a meal. There is a pact that it's important that, so there are some alternative schemes so you can reduce the intake of fat. In Brazil, the process is the registration is pending by Anvisa, so we're still waiting. Pexidartinib is not the only drug. We also have the emactuzumab, RG7155 recombinant, humanized monoclonal IgG1 antibody against the CSF1R, resulting in the dimerization domain to block ligand-induced receptor activation that depends on receptor homodimerization. We saw a type of response, which was very impressive, 83%, and some very pronounced responses reducing over 80%. We have some patients here with emactuzumab with dramatic responses, and the phase 1 study, which was published in the end of 2020, 63 patients, 71% was the response, significant functional improvements, and the tolerance was a little bit different than we had edema, pruritus, asthenia, and no depth. There is another one called cabiralizumab, phase 1 and phase 2 studies with very early data still, but reinforcing that the efficacy of the CSF1 with a mononucleonal antibody, and then the cohort had very important responses, and the tolerance profile is a little bit different too, the same way, prurity, edema, and then CPK elevation. There is a bigger level of CPK in these people. Imatinib too. We had imatinib before pexidartinib, and this is a retrospective series in 2019, including 62 patients. 4 individuals with metastatic disease, 71% with recurrent disease. These patients had 7-month treatment. 4 patients had metastatic disease. They had fast progression, and they were excluded of the analysis, resulting in 58 patients evaluated with no metastatic disease. And then we saw a response of 31% and a symptomatic benefits 108% and 48% with no progression in 5 years, having good control of diseases after the discontinuing with imatinib. So we're talking about a very rare clonal neoplastic disease that affects young and functional patients, characterized by cellular proliferation affecting the synovial tissue. The incidence in Brazil is still unknown, so the patients for surgery is the pattern, the standard for treatment, but we understand, we know that the diffuse is good. And in this entity, there is a rational molecular and mechanism for blocking of the receptor of CSF1 and this compelling clinical evidence supporting the use of pexidartinib. So we can use pexidartinib, imatinib, or monoclonal anticorps like emactuzumab for patients that are non-candidates of surgery. Thank you so much. Thank you for the invitation. And I'd like to speak about the Brazilian Orthopedic Oncology Congress in Gramado from 27th to 30th of April. This is my email address, and I'm here to answer any questions you might have.